So what is the definition of shock? The definition of shock is very, very important. Please try to remember it. It is defined as a state of cellular and tissue hypoxia with either reduced oxygen delivery or poor oxygen utilization. Reduced oxygen delivery or poor utilization of oxygen, or there is increased oxygen consumption with circulatory failure and poor perfusion. Okay, we can remember like it is a state of cellular and tissue hypoxia with either reduced oxygen delivery or poor oxygen utilization. This is one. And other one, we have increased oxygen consumption with circulatory failure. Circulatory failure which results in poor perfusion. So essentially, there is reduced blood supply or reduced supply or utilization of oxygen at the cellular level. I will repeat the definition once again. The definition of shock is it is cellular or tissue hypoxia, which is caused due to two things. One is either oxygen delivery is reduced, or there is poor utilization of oxygen in the tissue, or if there is increased oxygen utilization with circulatory failure leading on to poor perfusion. This is the definition of shock. The shock are broadly classified into four types. Those are hypovolemic shock, distributive shock, cardiogenic shock, and endocrine shock. What are these types of shock? In hypovolemic shock, there is reduced circulating blood in the body. When the circulating blood is reduced in the body due to trauma, hemorrhage, this results in reduced end organ perfusion, which is quite intuitive. And also we have distributive shock. Under distributive shock, we have septic shock. In the septic shock, the bacteria releases toxins, which causes vasodilation. Due to this vasodilation, the blood will pool inside the blood vessels, most commonly in the venous system. So when there is pooling of blood, even though adequate blood is present inside the body, it is getting pooled at one place, leading on to reduced cardiac output, which results in shock. So hypovolemic shock is seen in around 16%. Distributive shock is all contributes for 4% of cases. Cardiogenic shock contributes for 16% of cases, and also this endocrine cause is quite rare. Give me a minute. Yes, we'll remove this. So hypovolemic shock contributes for 16% of patient, and cardiogenic shock contribute for accounts for 16% of patient presenting with shock. Let's see hypovolemic shock. We saw that is due to hemorrhage, secondary to trauma. In septic shock, there is a release of toxins by the bacteria leading on to vasodilation and pooling of blood. Other kinds of distributive shock are neurogenic shock, and also we have anaphylactic shock. These are the three types of distributive shock. What happens in distributive shock broadly? There is pooling of blood inside the blood vessels, even though the blood is present within the body. So next, going on to cardiogenic shock. What is cardiogenic shock? Cardiogenic shock is due to impaired cardiac function, there is shock. We know how it is the pump. If the pump fails, the blood doesn't reach the end organs. doesn't reach the cell. If there's cardiac tamponade, if there is acute massive acute myocardial infarction, and other causes will lead on to impaired myocardial function and reduced cardiac output, leading on for shock. And at last, we have the rare cause, that is endocrine. We see in mixed edema, that is hypothyroidism, is associated with shock. Okay, we saw 4 types of shock briefly. That is hypovolemic shock, which is due to reduced blood; distributive shock, which is due to pooling of blood inside the blood vessels. Then we saw cardiogenic shock, which is due to pump failure, and we saw endocrine cause, which is due to hypothyroidism, mixed edema. The common causes of hemorrhagic shock are hemorrhage. It can also be due to burns. We already saw, we just discussed that point. And it can also be secondary to peritonitis, where there is fluid sequestration inside the peritoneal cavity. And also hypovolemic shock may be due to vomiting and diarrhea. The cardiogenic shock may be due to cardiac tamponade, acute myocardial infarction, acute pulmonary embolism, or other causes. These 3 causes is enough, I think. And the distributive shock, as I mentioned, is due to septic shock, which we'll discuss in deep. And then we have neurogenic shock. Neurogenic shock is due to sudden anxious or painful stimulus causing severe splanchnic vessels vasodilation. Here, the patient either goes for cardiac arrest and dies, or recovers spontaneously. And the other cause is spinal cord injury. Let me break down this paragraph for you. The neurogenic shock. The neurogenic shock is it may be due to anxiety or sudden painful stimulus, which causes splanchnic vasodilation. Due to splanchnic vasodilation, there is pooling of blood inside the GIT vessels, which leads to shock. And also it may be secondary to spinal cord injury. The spinal cord may be injured. We know T1 to T5, the supply to heart, and also we have sympathetic system. The spinal cord. The sympathetic system is the craniosacral outflow is this one. The thoracolumbar outflow is the sympathetic outflow. If there is damage to spinal cord at the level of thoracic or lumbar level, there will be vasodilation due to loss of sympathetic tone in the blood vessels. I hope you understood this. The neurogenic shock can be due to 2 things. That's due to anxiety or painful stimulus, or due to spinal cord injury. And also we may have anaphylactic shock, that is secondary to allergy, type 1 hypersensitivity reaction. We know the type 1 hypersensitivity reaction, 2 types, that is the priming phase, the effector phase, where there is release of chemical mediators in the effector phase. These chemical mediators lead to vasodilation, bronchoconstriction, etc. We know all these things. This is anaphylactic shock. Cardiogenic shock. In cardiac tamponade, there is pooling of blood in the pericardial cavity, leading on to compression of the myocardium, which in turn leads on to impaired contraction of myocardium. In massive acute myocardial infarction, there is infarction of myocardial tissue, so it can't contract adequately. So we saw in brief about different types of shock, that is hypovolemic, distributive, cardiogenic, and endocrine shock. Now let's go on for the interesting one, the pathophysiology of shock. What happens in pathophysiology of shock? See, in any kinds of shock, there is reduced cardiac output. What is cardiac output? That is stroke volume into heart rate. So in all these causes, in hypovolemic, distributive, and cardiogenic, there is reduced stroke volume. When the cardiac output is reduced, body tries to do one thing. The body always fights for survival. So it tries to maintain perfusion for vital organs like brain and heart in expense of vasoconstriction and reduced blood supply to other organs. This is associated with manifestations. So when there is reduced cardiac output leading on to splanchnic vasoconstriction and vasoconstriction at the level of kidney, there is reduced renal blood supply. Reduced renal blood supply may lead on to acute renal failure, which may lead on to metabolic acidosis. This is about reduced cardiac output leading on to vasoconstriction and renal failure. If there is reduced cardiac output, there will be hypoxia at the tissue level. Hypoxia at the tissue level will cause anaerobic respiration. Whereas when there is unavailability of oxygen, body goes on for anaerobic respiration and there will be production of lactic acid. Due to this reason, anaerobic respiration and due to renal failure, we see metabolic acidosis in shock. And also when there is metabolic acidosis and all the things, these things are going on, hypoxia is continuing, there is cell membrane function impairment at the cellular level. We know in pathology, cellular injury, that cell membrane function will get impaired before the cell death. When there is impairment of function of cell membrane, it leads on to electrolyte abnormality. We have increased concentration of sodium outside the cell. We have increased concentration of potassium inside the cell. The potassium tries to go out. The sodium and calcium tries to come in, leading on to hyponatremia and hypocalcemia. And the potassium comes out of the cell, leading on to hyperkalemia, which is seen in shock. So I discussed about reduced cardiac output leading on to metabolic acidosis by acute renal failure, and also reduced cardiac output leading on to hypoxia, anaerobic respiration, lactic acidosis, the electrolyte abnormality, and also when there is all these things is going on because the circulation is sluggish and due to endothelial dysfunction, there may be microthrombi developing inside the blood vessels all over the body. This development of microthrombi will consume the clotting factors. The consumption of clotting factors will result in hemorrhage, hemoptysis, bleeding from oral cavity, bleeding from mucous membrane, hematuria, etc., etc. This is called DIC, disseminated intravascular coagulation. DIC. So this of pathophysiology of shock. There's a reduced cardiac output leading on to vasoconstriction, reduced systemic perfusion leading on to acute renal failure, and cardiac output reduced leading on to hypoxia. There is anaerobic respiration, lactic acidosis, electrolyte abnormality, hyperkalemia, hyponatremia, and hypocalcemia, and also microthrombi developing inside the blood vessels leading on to consumptive coagulopathy, hemorrhage, disseminated intravascular coagulation. This is about pathophysiology of shock. Next, we'll proceed on to stages of shock. The stages of shock goes on like this. The already mentioned factors like infection, seen in septic shock, the burns, hemorrhage and hypovolemia leads to hypoxia. These effects. When there is hypoxia, it leads on to systemic inflammatory response syndrome. There is hypoxia leading on to systemic inflammatory response syndrome. where all the vasodilators, the inflammatory mediators are released. There is vasodilation here. There is increased endothelial permeability here. And there is thrombosis, as I already mentioned. This is about systemic inflammatory response syndrome, followed by all this leads to altered cytokine level and abnormal nitric oxide synthesis and abnormal arachidonic acid metabolism, neutrophilic activation, free radical production, altered complement activation, failure to have localization of inflammation. It is severe type of reversible shock. Okay, reversible shock. Let me explain. Due to hypoxia and many other causes, depending on the cause, there will be increased release of cytokines, increased release of inflammatory mediators, leading on to endothelial dysfunction and vasodilation, which is called as systemic inflammatory response syndrome, which is seen in severe type of reversible shock. And also after this we will have, if the condition is not addressed and it progresses, it may lead on to DIC because of previously mentioned causes. And if it continues, it leads on to MODY, that is multi-organ dysfunction syndrome. If there is multi-organ dysfunction syndrome, which we will discuss while discussing 5 marks, it is called irreversible shock. So let me explain the stages for you. First, there is hypoxia. From hypoxia to systemic inflammatory response syndrome, it's the spectrum of reversible shock. Give me a minute, I'll organize these things. Okay. From hypoxia to severe inflammatory response syndrome, it's the spectrum of reversible shock, where the patient has hypoxia and associated manifestation, lactic acidosis, electrolyte abnormality, and renal failure, all these things. It is called as reversible shock. There is increased cytokine release. There is increased release of inflammatory mediators, leading on for endothelial dysfunction and leading on to severe inflammatory response syndrome, systemic inflammatory response syndrome. Systemic inflammatory response syndrome is severe reversible shock, and then followed by that, if the disease is not adequately treated, or if the disease progresses further, will lead on to disseminated intravascular coagulation, leading on to multi-organ dysfunction syndrome. If the patient develops multi-organ dysfunction syndrome, it is called irreversible shock. I hope all of you understood this. Reversible shock from hypoxia to severe systemic inflammatory response syndrome spectrum, and then irreversible shock where multi-organ dysfunction syndrome is seen. Next, we are continuing with hypovolemic shock. We already saw the causes of hypovolemic shock. It may be due to hemorrhage, due to trauma. It may be due to loss of fluid due to burns. It may be due to loss of fluids and electrolytes, water and solutes during vomiting sessions, during vomiting and diarrhea. It may be due to secondary to sequestration of fluid in case of peritonitis. These are all the causes of hypovolemic shock, which is one of the most common cause of shock. These are all the causes. Coming to pathophysiology of hypovolemic shock, it's same as general mentioned shock. You can mention this. If the questioner asks pathophysiology of hypovolemic shock separately, it's same as we mentioned here. And then next, coming on to clinical manifestations of hypovolemic shock. Clinical manifestations of hypovolemic shock is divided into early and late manifestations. Early manifestations are tachycardia, sweating, cold periphery, hypotension, restlessness, air hunger, tachypnea, oliguria, and collapsed veins. So I mentioned so many symptoms at once. I'll break down it for you. So initially, when there is reduced blood inside the body, the baroreceptors will get activated. The stimulation of baroreceptors will lead to activation of sympathetic system at the medulla oblongata. This leads to tachycardia, sweating due to sympathetic activation. There is cold periphery due to cutaneous vasoconstriction. There is hypotension due to loss of fluid. There is tachypnea and oliguria due to reduced renal perfusion, and collapsed veins due to reduced blood inside the circulation, inside the circulating blood due to sympathetic activation. This one. Okay. The early manifestations are due to sympathetic manifestation, tachycardia, sweating, cold peripheries, hypotension, collapsed veins, and oliguria due to reduced blood. And also we have tachypnea, air hunger. What are the late manifestations of hypovolemic shock? Those are cyanosis, anuria, jaundice, and drowsiness. Cyanosis because as the hypoxia continues, when the reduced hemoglobin's level increases more than 5 gram percentage, it leads on to cyanosis. And there is anuria. I mentioned it during acute renal failure. The prolonged prerenal cause will result to renal damage, acute tubular necrosis, which presents with anuria. If you are not, if this point is not clicking, you can watch acute renal failure video. You will correctly understand that. And then we have jaundice and cyanosis, jaundice and drowsiness. Jaundice due to hepatic injury secondary to reduced blood supply, and also the patient may have drowsiness. These are the clinical manifestations seen in hypovolemic shock, early and late. The hypovolemic shock may be classified into compensated, mild shock, moderate shock, and severe shock. Clinical staging. Clinical, it's better to mention classification. Compensated shock. Compensated shock as mild tachycardia, normal BP, normal urine output, and also the patient have normal respiratory rate with mild lactic acidosis. This may be following the if you donate blood, following that there is mild loss of 300 to 350 ml of blood from your body into the sorry, there is mild the blood from your body is being taken for blood donation. So there will be compensatory mechanism acting, leading on to mild tachycardia and these things. The compensated is benign one, it will get corrected by itself. So it's called compensated. In case of mild shock, it has mild lactic acidosis, tachycardia, not mild, tachycardia, significant. And also the patient have tachypnea and anxiousness. Along with these things, if you go to moderate shock, the patient has reduced urine output. If you go to severe shock, the patient has anuria, severe tachycardia, profound hypotension, and unconsciousness. This is the clinical spectrum of hypovolemic shock. ranging from compensated to severe shock. The compensated shock, the only manifestation is mild tachycardia. In case of mild shock, the patient have mild lactic acidosis and tachycardia, which is not so severe. And also in moderate shock, along with these things, the patient will have reduced urine output. In case of severe shock, the patient has anuria, profound hypotension, and unconsciousness. This is about clinical manifestations of hypovolemic shock. Then we'll go on for assessment, investigations, monitoring, and treatment of hypovolemic shock. Coming on for assessment, investigations, we have regular monitoring, very important, regular monitoring of BP, pulse rate, heart rate, respiratory rate, and urine output. The urine output should be more than 0.5 ml per kg per hour. While discussing acute renal failure, we discussed one of the criteria for mentioning it as acute renal failure, the KDO classification is less than 0.5 ml per kg per hour urine output. Please connect this with that point. So, in case of hypovolemic shock, we continuously monitor blood pressure, heart rate, respiratory rate, and urine output. Why we are monitoring? Because we are checking the response to treatment by these things. If the patient's BP is improving, if the heart rate is reducing, and the urine output is increasing, respiratory rate decreasing, it shows that the patient is clinically improving. If the opposite occurs, it means that the patient is clinically worsening, and we should take adequate steps. After this, we have central venous pressure monitoring. For central venous pressure monitoring, we need ICU setup. Central venous pressure will give us the right atrial pressure, so we can adequately monitor the fluid response. After giving the fluid, we can monitor the response, whether there is orgoic hemorrhage or not, whether the patient is responding and all. We can do it by doing continuous venous pressure monitoring. Continuous venous pressure is a separate topic. We'll see if we get time at last, we can discuss that. And also the usual manifestation, usually done investigations, we'll do complete blood count, ESR, pH assessment, serum electrolyte. Serum electrolyte, I already mentioned what happens. With respect to serum electrolyte, there is hyperkalemia. This is very dangerous because it can lead on to arrhythmia. There is reduced calcium levels and reduced sodium levels, hyponatremia and hypocalcemia. These are also equally dangerous. And also we'll see for pus, urine, blood, bile or sputum cultures, depending on the focus of infection, it is done in case of sepsis. We should also do serum lactate level estimation. It is an important prognostic factor. The level more than 2 milliequivalent per liter is suggestive of ongoing ischemia. So continuous monitoring should be done. As we treat the patient, as the patient get better, the serum lactates level will come to less than 2 milliequivalent per liter. And also we can do renal function test. Why? Because we can see acute renal failure in case of hypovolemic shock and other kinds of shock. And other most important one investigation is USG assessment of IVC diameter. As please note these points, because IVC diameter estimation is done in case of many conditions, in case of dehydration treatment in pediatrics, in this one, and it comes many times while studying. So using M mode in ultrasound, we'll do IVC diameter monitoring. We'll do the measurement of IVC diameter, inferior vena cava diameter measurement. If it is less than 10 mm, the patient needs proper fluid therapy. If it is more than 25 mm, it means there is fluid overload. So we have ultrasound in the emergency department and in the anesthesia department and all, where we can put M mode and measure the IVC diameter. If it's less than 10 mm, it means the patient needs fluid therapy. If it's more than 25 mm, there is fluid overload. Please don't give more fluid to this patient and worsen the condition of the patient. This is about investigations in shock. In general, also these are the commonly done investigations. But hypovolemic shock also this is done. I will mention what are the additional investigations done in septic shock. It is quite intuitive. We'll send blood for culture and we'll do USG, CT, MRI to localize the focus, septic focus. Blood culture and sensitivity. We can also do urine culture and sensitivity. So, in general, these are all the investigations done in shock. Monitoring of BP, heart rate, respiratory rate, urine output, and then CB, the routine investigations. The serum lactate level, most important, if it's more than 2 milliequivalent per liter, it indicates a reduced, it indicates tissue hypoxia. RFT we should do because we may have acute renal failure. Also ESG, IVC diameter, central venous pressure monitoring, and in the case of septic shock, the additional management investigations are blood culture sensitivity, USG, and urine culture sensitivity. I hope all of you understood the investigations in case of shock. Let's proceed on for treatment in case of shock. Let's see the treatment of shock in general. So as always, initial critical care management is very important. That is ABCD. We can't forget this. Management of airway, breathing, circulation, and disability, and drugs. Exposure as a ABCDE. Exposure as a primary assessment and resuscitation should also be done. This is in we all know these points. I will not be elaborating on each points now. Then we have fluid replacement. In hypovolemic shock, the main thing what we know is the cause is reduced blood supply. So thereby we should do adequate fluid replacement. In the initial first 24 hours, ringer lactate is the solution of choice. So we can give plasma, normal saline ringer lactate, and also ringer lactate. We can give plasma expander that is Hamacil. This plasma expander Hamacil can be given only up to 1 liter per 24 hours. And then following that, fluid therapy is ideally done with crystalloids. We know that the blood loss should be corrected by blood transfusion only. Please note this point. If the patient has blood loss due to RTA, it should be corrected with blood transfusion only. The crystalloids and colloids do not have oxygen carrying capacity. Why I am telling that the blood transfusion should be done if the cause is blood loss? Because when the blood is lost, the RBCs are lost. What is the primary function of RBC? Is to carry oxygen. If we don't have adequate amount of RBCs inside the blood, inside our body, who will carry oxygen from the lungs to the cell? No one will be there. If we go on giving ringer lactate plasma expander, the volume of fluid the volume of blood will increase, but it will be useless because RBCs are less. So in case of hemorrhage, we should do blood transfusion. And also we have, this is about fluid therapy. So I mentioned ABCDE as a initial management, followed by fluid replacement, usually in hypovolemic shock secondary to vomiting, diarrhea, and burns we saw in previous session. And also if the patient has hypovolemic shock due to hemorrhage, we should consider blood transfusion. Why I mentioned. We have other interesting concept called dynamic fluid response. The dynamic fluid response is studied by using 500 ml of warm normal saline in 10 minutes using 2 wide bore cannula. The responders show improvement. Transient responders show improvement temporarily but revert back to original status. Existing blood fluid or blood loss, or still fluid shift from intravascular space. Non-responders do not show response at all. Fluid therapy is considered as 20 ml per kg or adequate monitoring of urine output and all these things. I'll break down this for you. Dynamic fluid response. What we are doing? We are inserting 2 wide bore cannula and we are giving 500 ml of fluid over 10 minutes. Fly 500 ml of fluid over 10 minutes. If we give this, we have 3 types of response. One are responders, then transient responders, and non-responders. The responders are the patients where the parameters like BP, urine output, acidosis will be corrected following this therapy. We are happy because there is not so severe fluid loss and the patient is responding for our treatment. Will manage fluid adequately and then the patient will recover happily. What is happening in case of transient responders? In transient responders, they respond for some time because the fluid is given. It increases the perfusion for some time, but because there is ongoing loss, they will revert back to their original condition. That is their urine output, their BP, and all the other parameters which I mentioned previously will revert back to the normal, sorry, not normal, the original condition after some time. This is due to ongoing loss. We should search for cause of ongoing loss and correct it in case of transient responders. The non-responders are the ones who have severe hypovolemic shock. And they are at the end of the spectrum here. End of the spectrum. It is severe disease. It's a severe condition to have associated with high mortality. Okay, fluid therapy is continued as 20 ml per kg or 150 ml per hour. Fluid therapy is given as continue after dynamic fluid response, where we give 10 ml, 500 ml in 10 minutes. After that, we'll continue the treatment as 20 ml per kg or 500 ml per hour. This is about dynamic fluid response and fluid replacement in case of hypovolemic shock. And all after this, we should correct all the complication that is caused by this hypovolemic shock. By blood transfusion and giving fluid, we are catering with the primary cause, which is lead on to pathophysiological changes. That is fluid loss of less intravascular fluid, which leads on to acidosis and all. Now we should cater the secondary effects of this hypovolemic shock, where we have metabolic acidosis, which is corrected by giving sodium bicarbonate. And also we can give steroids. It's often life-saving 500 to 1000 mg of hydrocortisone can be given. It improves the perfusion, reduces the capillary leakage, and systemic inflammatory response. Steroids. I mentioned this point previously. Here you see, at the spectrum of reversible shock, at the point where the patient has severe reversible shock, he has systemic inflammatory response syndrome where there is increased secretion of cytokines and inflammatory mediators, which are increasing endothelial permeability and causing vasodilation, further worsening the condition. So to prevent this, we can give steroids. That is 500 mg to 1000 mg hydrocortisone. And also we can give antibiotics in case of patients suffering from sepsis. This is other one, not in hypovolemic shock. The catheterization should be done. I should have mentioned this first itself. Catheterization should be done to monitor urine output. The urine output should be maintained more than 0.5 ml per kg per hour or 30 to 50 ml per hour. Nasal oxygenation to improve the oxygen level, SpO2, oxygen saturation inside the body. Hemodialysis may be necessary if the patient's kidneys stop function. I mentioned. I'm not mentioning it again. Acute renal failure. Hemodialysis. And to control pain, we can use morphine. If the patient has severe disease, we can use ventilator support, ICU care, injection of ranitidine and omeprazole, pantoprazole. And also, at last, I am mentioning about military anti-shock trouser. It provides circumferential external pressure of over 40 mg. I hope all of you have seen military anti-shock trouser. It comes like some inflated balloon like thing which is wrapped around the legs, which gives the external pressure of 40 mm of Hg, which is wrapped around the lower limbs and abdomen, inflated with required pressure. It redistributes the existing blood from the lower limb towards the heart. Thereby, it may help in treating the condition. So, we had discussion about investigations and treatment stages, pathophysiology of clinical manifestations of hypovolemic shock. Clinical manifestations are early, late, and classical clinical classification, compensatory, mild, moderate, and severe shock. And then we saw treatment, early ABCDE management, followed by fluid replacement and blood transfusion, which caters the primary cause. The secondary effects like metabolic acidosis should be maintained with NaHCO3, SIRS maintained with steroids. Steroids very useful. Acute renal failure, if severe, hemodialysis, morphine to control pain, and also the fluid therapy. Here we give 220 ml per kg or 150 ml per hour. We talked about dynamic fluid response, and at large, I mentioned few things about military anti-shock trouser. I hope all of you understood the hypovolemic shock in deep. After this, we have to talk briefly about two things, that is septic shock and multi-organ dysfunction syndrome. Septic shock. Septic shock is the one of the type of distributive shock due to pooling of blood secondary to bacterial toxin release. The septic shock is most commonly due to gram-negative organism. Like gram-negative organ, it can be also due to gram-positive organisms, fungi, virus, or protozoans. This point is very important because most of us think that septic shock is only caused by bacteria? No, the answer is no. It can be caused by gram-positive, gram-negative bacteria, fungi, virus, and protozoans. Note this point. Gram-negative septicemia, gram-negative septic shock is called as endotoxic shock, which I mentioned previously. Endotoxic shock. It occurs due to gram-negative infection, seen in strangulated intestine, where the intestine are strangulated. Intestine gets strangulated in case of hernia, strangulated hernia. The strangulated intestine can cause septic shock secondary to infection, and also it can also be seen in case of peritonitis, GIT fistula, biliary pancreatitis, diabetic wounds. I mentioned it can be due to any microorganisms. So gram-negative organisms causing septic shock is due to secretion of endotoxins. It is called as endotoxic shock, which may be due to strangulated intestine seen in hernia, strangulated hernia, peritonitis, pancreatitis, diabetic wounds, etc. etc. Let's proceed on to pathophysiology of septic shock. First, there is release of toxins, endotoxins from gram-negative bacteria, which have many effects. It causes inflammation, activation of inflammatory cells. The endotoxins present inside the blood will activate inflammatory cells. The inflammatory cells, we all know, after activation will release cytokines and free radicals. When there is release of cytokine and free radicals, we have studied in our pathology that there is chemotaxis and recruitment of more inflammatory cells. There is endothelial injury and also altered coagulation cascade leading on to SIRS, which we briefly touched while mentioning the pathophysiology of shock in general. Okay. This leads on to reversible hyperdynamic warm stage of shock with fever, tachycardia, and tachypnea. This leads on to reversible hyperdynamic warm shock. If it continues and leads on to multi-organ dysfunction syndrome, MODY, when there is myocardial failure, the pump failure, there is reduced systemic perfusion, there's hypodynamism, hypodynamic circulation, irreversible cold stage of septic shock. So, MODY. Yes. Syndrome. Okay. What is the pathophysiology of septic shock? There is secretion of endotoxins by gram-negative organisms, which leads on to activation of inflammatory cells, which release cytokines and free radicals, causing chemotaxis and endothelial permeability impairment, leading on to systemic inflammatory response syndrome. At this stage, it is reversible hyperdynamic warm shock, where there is pooling of blood in the periphery. Blood is pooled in the periphery. When the blood is pooled, when there is increased blood in the cutaneous circulation, it leads on to warming effect. So it's warm shock, septic warm shock, reversible hyperdynamics warm shock, warm septic shock. If it continues and lead on to multi-organ dysfunction syndrome and there is pump failure, it leads on to hypodynamism. It's called as hypodynamic irreversible cold stage because heart is not pumping blood, and there is reduced blood in cutaneous circulation, leading on to cold periphery. Cold periphery. At the presentation, if you see warm peripheries with the features of shock, suspect septic shock. If the at the presentation you will see reduced blood pressure, reduced urine output, tachypnea, and increased heart rate, increased pulse rate. With cold peripheries, you suspect hypovolemic shock and all. With warm peripheries, we suspect septic shock. So septic shock is typically vasodilatory shock, wherein we have peripheral vasodilation. We already mentioned that we have magnitude of septic shock. Magnitude. It can be mild septic shock. It can be, we have magnitude of not septic shock, we have magnitude of infection. Sorry, magnitude of infection varying from mild sepsis. This point is very important, please listen carefully. Severe sepsis and septic shock. How to differentiate these things? So, if the patient with mild sepsis shows fever, tachycardia, and leukocytosis, which we encounter daily. And if the patient has severe sepsis, he show or features of reduced organ perfusion, where there is lactic acidosis, hepatic dysfunction, acute renal failure, and dysfunction of pulmonary system. There is reduced organ perfusion in severe sepsis. What happens in case of septic shock? There is systemic hypotension. Systemic hypotension. BP less than 90 mmHg in spite of adequate fluid therapy. BP less than 90 mmHg in spite of adequate fluid therapy. There is severe organ dysfunction. We already know the organ dysfunction is present in severe sepsis also, but it is severe in case of septic shock. There is maldistribution of fluid flow. We already know that in despite of adequate fluid resuscitation, the patient blood pressure doesn't pick up and he need vasopressors like epinephrine, hydrophonium, and others, dopamine, dobutamine, other vasopressors. He requires vasopressors to maintain blood pressure, mean arterial pressure more than 65 mmHg and serum lactate levels more than, and serum lactate level will be more than 2 millimoles per liter. That is the other point you leave. So we saw spectrum of infection: mild sepsis, severe sepsis, and septic shock. Sepsis is the organism thriving inside the blood vessels. There is bloodstream infections. In mild sepsis, there is fever, tachycardia, leukocytosis. In severe sepsis, there is reduced organ perfusion, leading on to manifestations like lactic acidosis, hepatic dysfunction, acute renal failure, and pulmonary impairment. In septic shock, please note there is systemic hypotension. The systolic blood pressure is less than 90 mmHg, and the organs are severely dysfunctional. In spite of adequate fluid resuscitation, the patient requires vasopressors to maintain mean arterial pressure more than 65 mmHg. This is about spectrum of infections. The dead end is septic shock. The definition, causes, and pathophysiology of which we discussed. So after this, we have clinical manifestations. We already know the clinical manifestations. I briefly touched upon two phases in an arm. of septic shock, that is reversible hyperdynamic septic shock and hypodynamic irreversible hypodynamic hypovolemic septic shock. Let's discuss briefly about these 2 points. In reversible hyperdynamic septic shock, the patient, the condition is reversible. The patient has inflammatory response. So, as clinical manifestation, the patient has fever, tachycardia, and tachypnea. The pyogenic response is still intact. The patient should be adequately treated in this phase to prevent him from proceeding on to hypodynamic irreversible cold stage. And also we should do management investigations. We should do blood culture sensitivity, and we should treat the patient with adequate higher antibiotics. Higher antibiotics like third generation cephalosporins, aminoglycosides, metronidazole are started. We see we are covering all the organisms, gram positive, gram negative, and anaerobic organisms here. And also the underlying cause should be adequately treated. While mentioning about idiopathogenesis, the causes of shock, I mentioned the primary insult is different. That is, it can be strangulated, hernia, peritonitis, pancreatitis, diabetic foot. Until and unless you cater this, the septic shock continues. So, giving only antibiotics doesn't help. We should tackle these conditions adequately. And also, ventilatory and ICU support may help. ICU and ventilatory support may help in preventing the patient to proceed on for hypodynamic irreversible cold stage. Now, what is hypodynamic irreversible cold stage? Here, the pyrogenic response is lost, meaning the inflammatory response, leading on to fever, tachycardia, and all leukocytosis and inflammatory response, systemic inflammatory response syndrome is lost. Rather, the patient is in decompensated shock. Decompensated shock. It is an irreversible stage where MODS is seen, multi-organ dysfunction syndrome, with, we all know what is there in MODS. We already discussed in while discussing hypovolemic shock. We have anuria, respiratory failure, cardiac depression, pulmonary edema, hypoxia, and eventually the patient may develop coma and may even die. So this is about clinical manifestations. We divided it into two types: reversible hyperdynamic, hypodynamic irreversible cold stage. I hope all of you understood this. And then at last we are proceeding in for treatment of septic shock. The septic shock should be treated by giving adequate fluid and electrolyte management, fluid resuscitation, and most importantly, appropriate antibiotic treatment. The antibiotics preferred are, I already told, those are third generation cephalosporins along with aminoglycosides and metronidazole. Broad spectrum, we are calling all the organisms, gram positive, negative, and anaerobic. Also treat the primary focus of infection, drainage of abscess drainage in case of the patient has infection and abscess collection anywhere in the body, drainage of the abscess, laparotomy for peritonitis, resection of gangrenous bowel in case of strangulated hernia, and also wound excision in case of diabetic wound or wound debridement. The pus, urine, and discharge should be done for culture sensitivity. We all know that. The critical care, oxygen support, ventilator support, dopamine support, and also we should continuously monitor BP and urine output. We all know that. We already discussed it nicely. Activated C protein prevents the release of inflammatory mediator and blocks the effects of this mediator on cellular function. Okay. And also, the short-term high-dose steroid therapy helps. short-term high dose steroid therapy. We discussed in hypovolemic shock that giving 500 to 1000 mg of steroid hydrocortisone will help by preventing the effects of systemic inflammatory response syndrome. So, meanwhile, here also the high dose short term steroid therapy is useful to control and protect the cells from effects of endotoxinemia. It improves cardiac function, renal function, and lung function. What we are giving here, please note, we are giving single dose of methylprednisolone or dexamethasone, which may be repeated again after 4 hours, and it is said to be effective in case of shock secondary to endotoxins released by gram-negative bacteria. This is the very interesting point. Please note this. Giving short-term IV steroid. Okay, septic shock. We discussed about pathophysiology, the causes, the treatment, fluid management, antibiotic therapy, treatment of primary focus, short-term high-dose steroid therapy, which is of help. We usually think that giving steroids is not acceptable in case of septic shock, but it's not the case. Giving steroids is found to improve the cardiac function, renal function. So we should give single dose of methylprednisolone or dexamethasone, which can be repeated 4th hourly. Meanwhile, we should monitor BP, urine output, and lactic acidosis levels. This is all about septic shock. Let's see the questions. We are finished with shock, septic shock. This one finished. Principles of resuscitation. We saw septic shock. Okay. Measurement of central venous pressure. I told you it's a 1 paragraph. Please go through it. SIRS, systemic inflammatory response syndrome. Okay, it's remaining. Multi-organ failure. We discussed this so many points, so many times in septic shock and hypovolemic shock. It's already done. Already done. Done. Okay. Okay, classification of shock we saw. Endotoxic shock we saw. SIRS we'll see now. MODS we saw. Hyperbaric oxygen. Please go through this. Some points about hyperbaric oxygen. Hyperbaric oxygen. I am leaving it for you.